Okay, so now I'm feeling a little more comfortable in managing these side effects. And for that patient that is in my clinic, I am repeating CAT scans and brain MRI regularly while they're on this treatment. But then, as we're talking about brain MRI, this brings us back to where we started, the patient selection. Stephen, when it comes to small cell lung cancer, CNS involvement is something we always worry about. IM-Forte excluded patients with CNS mets. In a patient with de novo brain mets who has undergone whole brain radiation upfront and is now starting systemic treatment, is this still a fair approach? And do we have any hint of lurbinectedin having CNS activity?
Yeah, I think it's a pretty critical question. We don't have a lot of activity or a lot of evidence of activity for CNS mets for lurbinectedin. This is not what I would consider a very CNS active drug. And so those patients were excluded from the study. They were also excluded from Empower 133. And I think it's really just to try to keep that patient population very homogeneous, to isolate the question, have as few variables as possible. This is a setting where if patients had brain metastases, I would still feel comfortable with the maintenance lurbinectedin approach, but I would really pursue treatment of the brain metastases with radiation therapy. And so if the patient had had those brain metastases radiated, I would feel very comfortable with this approach if they met all the other relative criteria. If someone had small asymptomatic brain mets that were not radiated, we started with therapy, we had a modest response, and then we were considering maintenance lurbinectedin, before we considered that maintenance approach, I would radiate those, I would treat them. And if you look at the IMforte study, patients were allowed to have prophylactic cranial radiation. Not many did, but you could have it, and they allowed for 9 weeks from the end of induction to the start of maintenance, and that's sort of the time frame with which I would pursue radiation therapy if someone did have brain mets. So I would treat them, but those patients, if anything, I think are at higher risk for relapse and potentially more likely to get benefit from a more aggressive maintenance strategy.
In those settings, are you still doing MRI every 3 months, or are you doing it sooner?
I still am doing it every 3 months, yes.
CNS involvement in this particular disease is indeed a challenging topic. TCN, another practical implication that we are tied in, especially in community and even in academics, is that the use of durvalumab, because patients are on carboplatin, etoposide, and durvalumab now, the maintenance option with atezolizumab and lurbinectedin. When it comes time for maintenance, are you switching them to atezolizumab, lurbinectedin?
Good question. I think that's a really tricky one because the way that the regimen was studied and showing the benefits was with this combination. So I think if I had in mind that this patient would be eligible for maintenance with lurbinectedin, I would certainly choose the induction strategy with atezolizumab up front and would try to avoid the switch. But I think in certain situations, would I do the switch? I probably would, but I think that, I would rather start with atezo up front in the induction strategy.
And Rohit, the reason why you're bringing that up is durvalumab being every 4 weeks, whereas atezo is every 3 weeks, and lurbi is every 3 weeks. So from the get-go, I think that you and I have chit-chatted about this as well, that in my practice from the get-go, you're having that discussion saying your whole treatment paradigm is chemo immunotherapy induction, and then you're switching to that maintenance phase with lurbi immunotherapy.